So yeah, I guess we can just kick you off today. We have a topic which is PCP engagement. So when we were doing our surveys at the beginning of this new year, we there was a lot of responses around wanting to have more discussions about PCP engagement. So we reached out to Jen and asked if she would be willing to talk to us a bit about that. So she's gonna, and then she um, I believe has someone with her. Not sure who it is.
It's
Um,
going to be Christine Onstadt, lovely internist at Northwestern, but she's
okay.
out of the country. And she was like, I can try to join. I'm like, you know what? Enjoy your vacation. You can come next month.
Yeah.
So,
Yeah.
yeah.
Yeah, for sure. Okay. So Jen's gonna lead us through a presentation and then we're gonna have just a group discussion around this topic. And so that is the agenda for today.
Sounds great. All right. Well, hello, awesome people in the SIG. My name is Jen Thomas. I am a family medicine and addiction medicine provider by training. My shop where I do integrated care locally is in Morris, Illinois. So we're about 2 hours southwest of Chicago. So we're pretty rural. Our integrated care journey really began because of Annie and folks at the AIMS Center that were fortunate enough to let us join a research trial. So we got implementation coaching from AIMS Center, and that's why we got our foot in the door with doing anything collaborative care related, because we're a thin margin nonprofit independent health system that serves a lot of folks with social determinants of health, high Medicaid population, and so it's tight. We don't have money laying around to do things new. But yeah, so why I'm talking to you, I am a PCP, so I learned of the collaborative care model at a primary care psychiatry training. And it really, like, I mean, cheesy, but it spoke to me. I was like, oh, that approach, that triangle, where if I had a psychiatrist helping me and a care manager that could jump right in the room and do some brief interventions, that could really work. That could move the needle with a lot of the stuck points I have in working with my people in primary care. So today I was just going to try to sum up a few things. The whole, PCP engagement, it's an elusive group, right? Providers, they're busy. Their bandwidth to like listen to anything new is slim. I mean, you think that's why the whole marketing push with, drug reps is like bribe them, give them lunch. Maybe they will look at you for 30 seconds, and it doesn't have to be like that with integrated care. It's more relationship based, but just starting off with, the culture of primary care is busy. So whatever you can do to help those PCPs hone their elevator pitch or just how they describe collaborative care, we found in our system that helped a ton. So we put it in a dot phrase in the EHR. We put it in some education, like we'll have a monthly huddle or a provider meeting, and then we're like a standing agenda item. And we're like, hey, let's just do a quick touch point on integrated behavioral health. Just as a friendly reminder, here's a phrasing of how you can introduce collaborative care to your patient in the moment. So again, that's kind of been like a nice element that really helped some of our early providers that were kind of earlier, newer to the model, kind of get the gist of like, how do I describe this? What does this look like in real life? And again, that kind of team-based care might be new for patients and providers. They may be used to just referral to specialty care, right? Where it's like, just here's your referral, you'll call the care, I'm handing it off to someone else. So really, zooming in on this is team-based care in the primary care setting. We're not referring you, we're not putting you, outside of here. We're just bringing in additional teammates to primary care. And just remembering that, those PCPs have such a golden opportunity for engagement. They're the ones that have had years of relationship with a patient and maybe their kids or their parents or their neighbors. They're really pillars of those local communities because all healthcare is local, right? Everybody that we do these models, but it's who we see in our shop, our community, our health system that delivers it. So really kind of leveraging like, hey, if the PCP vouches for this, it goes a long way with your patient to really say, okay, maybe we'll give this a shot. So the talking points we kind of really coach up our PCPs is, why shouldn't we just continue with usual care? Why even do this at all? Should we just do referral-based care? So we like to touch a little bit on, evidence. Clinicians usually like data. We can say, hey, there's a, wide evidence base. There's what now over 100, I think, correct me if I'm wrong, randomized trials that says, hey, this approach gets the job done better with better patient satisfaction and it's less expensive. And we can apply it to not just depression and anxiety. There's emerging evidence for PTSD and chronic pain. We also know that the PCPs feel more satisfied with this approach because I don't know about you guys, but there's nothing more frustrating about sitting in front of the same person and knowing they get care somewhere else and you can't talk to that person. I mean, it's the siloing is frustrating because it's like if I'm treating you and maybe the psychiatrist in specialty care is treating you and they're adjusting the meds, but I'm adjusting the meds, you can see how frustrating that is, not just for us as the providers, but also the patient, because then it's kind of a, are my providers on the same page? Other things you can hone in on is those early intense interventions by the behavioral health team help get patients better quicker, early depression remission. And then just normalizing that, only 30 to 50% of people get better with their first treatment attempt. I love quoting Anna Ratzlaff has been a mentor of mine with AIMS. And I remember her saying early on in our training, this is an iterative process. Okay. So we are going to have to look and relook. And if it works, great. If not, we have to come back to the drawing board and adjust the plan. And that's okay. That's expected. So when we're onboarding and training new PCPs, at least in our shop, we really try to have them get just some bare bones understanding of the model. And this investment in time early on saves you a ton of headache a month from now or a year from now. Because well-meaning clinicians like, oh, okay, I get it, it's collaborative, it's team-based, right? But if they're not really getting the model or the core principles, you can go off the rails and have drift pretty quick. So in our shop, we say, hey, PCPs take the APA free training. You'll get CME credit. You'll understand the bare bones of CoCM. I like to share the AIM Center's Daniel story. We've shared this with all sorts of audiences, kind of the managers at our health system, our hospital board system, because I like the narrative approach with this, that in about 7 minutes, you see the aspects of the model through the lens of a real person, like, hey, I was struggling with depression. Here's how I got care. And I think, Andy, you're the care manager in that video, if I'm not wrong. So yeah, it's a goodie.
Yeah, it's like 20 years ago. Yes.
All right. It's a throwback, but it's still,
Yeah.
still works.
A baby care manager. Yes.
Well, hey, it's good stuff. All right. So I also think, acknowledge the elephant in the room. PCPs, don't you already have enough to do? We do, and that's okay. um, and they're burnt out. So I think just acknowledging that head on, right? They spend a lot of their time doing other things besides direct patient care. A lot of pajama time. That's kind of the cute way of saying, oh, you're documenting at night and at weekends when you should be, sleeping and living your life. But responding to inbox messages. Now there's portal messaging, refills, labs. There's a lot of touch points that PCPs do in addition to their direct patient care. So even if they see 15 or 20 patients a day, they're probably touching 40, 50 more patient lives with all the messaging and interaction with each chart that they're doing. So there's a lot on their plate. So I kind of like to throw this up with my providers and be like, yeah, let's just talk about it. Don't I do a good job at behavioral health? Like you're saying, I don't do a good job treating my patients' depression? No, we're just saying maybe it's a little easier and quicker for you if you have some additional hands. If you get stuck, the psychiatrist can help. It's nice to tag a behavioral health care manager into the room to say, hey, Mike's a member of my team. He can come meet you right now, talk about some coping skills with your grief or some ways we can help you sleep better. I kind of like to talk through is this more work for me? That's a big hesitation because again, if it's anything that's like, this is going to be more work for me as the primary care provider, you're probably going to lose them. So again, you're thinking of it as like helping lighten the load. You're carrying the load together because people are still going to come into primary care with their needs, whether we have a team or not. It's still going to be, okay, PCP, throw all this on your lap, help me deal with this. So rather than the PCP carrying it all by themselves, you've got others to help you carry that load. Some people get kind of hung up around the prescribers like me. I think in our shop, that was more of an early concern around like, ooh, am I going to be, should I be, can I be writing, psychotropic meds? I remember I had one doc that was kind of a early, no, thank you kind of guy. I was like, should we really be doing this? Like we're not psychiatrists. I don't know if we should put our toe into this. I'll say, in his case, he came around just because it was modeled by his colleagues. So he's in a shop with two pediatricians and another FP, and it was like, oh, what are they doing down the hall? Cheryl's going into that exam room with the pediatrician talking to the patients. That's neat. And lo and behold, in time, he was like, maybe I'll give this a try. And I was kind of one of our biggest champions. And again, just why can't we refer out? You could, if co-located care gets the job done where you are, great. Nationally, I think obviously the data shows us that, patients that get referred, what is the average number of visits to a specialty is 2, and half of those patients that get referred don't even make it there. So again, primary care is that golden opportunity. I love Lori Rainey's slide. This is an old slide, but it's a really goodie too, about PCP experiences. So maybe you kind of just acknowledge these from the get-go. Hey, are you worried this is going to slow you down? Well, you might find that after you're doing this for 3 months or 6 months, you feel like it helps lessen the load on your plate. PCPs often are very resistant to that. I don't have time to address one more problem. I can't do it. I can't screen for it if I don't know what I'm going to do with a positive. But in time, the data shows that PCPs feel like, oh, this actually helps speed me up. Um, and then, this provider is pretty in a bad place. I think this is going to drag me down like an anchor. Maybe, but I think most people feel like this actually helps me work up more efficiently. So again, I think if there's things, and again, this is published data, you can say, hey, well, here's what an actual, qualitative scientific approach said about this work. And then this is just sort of my perspective around like having a PCP champion. That was what I was in my system when we first got started with this. So again, we joined the AIM Center research trial and they're like, okay, we need a PCP champion. I was like, okay, I think this model's cool. I'll be the champion. How does that look in time, or what does that actually mean? It's just having a designated provider that is kind of the ambassador. So again, you're willing to like talk it up to your circles, right? Whether it's your providers or leadership, your patients, you're really kind of, championing or campaigning for this concept of team-based care. But growing the PCP champion, I think that's something that every site needs to really look at and look at your talent pool in your workforce. So I would say, look at your primary care providers, get to know them. Who's interested in behavioral health or substance use? There's probably some PCPs already doing that. They may be your PCP champion in the making. They just don't know it yet. Are there any of them that like the quality improvement work? Are any of them wanting to do more of a leadership role? I think you'll find a lot of PCPs, at least my colleagues, when they get kind of mid-career, or maybe even from the get-go, they might like, hey, I like doing patient care 24/7, but that's kind of taxing. So maybe I want to do a hybrid. Maybe I want to have a part-time leadership role or a little bit of leadership with a champion role and still do clinical care sometimes. But really investing in those relationships, because if you're tasked with let's do this in my system, your system, knowing your people and what their interests are is important. And then really zooming in on the culture of primary care. So I don't know about your systems, but I think it's really important to know that leadership top down buys into this concept that we believe whole person care is how we do primary care. It's not a program, it's not an other, it's not referring. It's really kind of transforming the mindset of this is just part of how we treat chronic conditions, including behavioral health. So it's more bread and butter for primary care rather than this nice to have, but we don't have to have it. It's like, nope, this has to be a core value of what we do. So this is just a copy paste. This is a really big slide. If you ever in a situation where you need to like create a job description, I fully support, copy paste this for somebody of like, hey, who's my PCP champion? What does that look like? And so you could say, well, for example, you could devote 2 hours of time with collaborative care leadership duties. And here are some of the duties this person might do. And then if that helps kind of relay that out to the larger health system of, all right, Dr. Smith's our PCP champion, and now he has this role where he's going to be the one talking to you about, measurement-based care and the importance of universal screening, so that they start associating that provider with this leadership role. They're not just kind of a bossy, nosy PCP know-it-all. It's like, nope, this is their role. We have deputized them with this role. I threw this in here just because I don't know if everyone kind of is in the lingo of like, how did docs get paid? WRVUs, work value or relative value units. So real quick, a WRVU is just a unit that is assigned to the amount of time, skill, intensity that a provider provides in their patient care. So each CPT code has a designated RVU. And then that is multiplied by what's called a conversion factor. So for me in family medicine, the conversion factor dollar amount is about $45. So I'm giving you an example. Let's say you come see me as your primary care provider for an anxiety med follow-up. I'm like, how you doing? You're doing good. Symptoms are great. Awesome. Continue your Lexapro 10 milligrams. I'll see you in 3 months. That's a low complexity visit. So that's a 99213. And I, as the provider, accrue 1.3 WRVUs. But let's say my next patient's a little more complex and he's coming in saying, I'm really depressed the last month. And we give him a PHQ-9 and his score is high, it's 20. And he's like, yeah, 10 years ago, I had a really bad bout of depression and I felt suicidal. and they had to admit me. Now I've been good for 10 years, but about a month ago, things really flared up. I've missed a lot of work. I'm not doing so good. So maybe I say, hey, well, one of the ways we can help you is you can meet Mike. We have he's part of my care team. He helps me with people that have, stress in their life or behavioral health conditions. He can meet you right now and talk to you about how we can help you get feeling better quicker. The other member of the care team is a site consultant. Dr. Norell is my site consultant. She's wonderful for helping us if we get stuck around, medications. And all three of us are going to work together to help you feel better quicker. What do you think about that? So kind of that elevator pitch right there live. But again, for him, he's a little more moderate complexity. So we might be ordering labs. So he would be a level 4. So we get a few more RVUs because it's a little bit more complex. So again, this, and I promise I'll shut up, is a concept of, let's say you get that PCP champion and they're like, I'm doing great, but I'm burning out. I can't have a full-time job as a provider. I need to have a leadership role for this. So how could you approach this from the leadership side that's talking brass tacks budget? One option you could do is give them an RVU credit. So let's say this might work well in a system where some systems pay docs completely on RVU production. So we'll say, all right, Dr. Smith is going to get a credit of 13.5 RVUs to compensate for those 2 hours. Because let's say Monday morning from 9 to 11, he's not seeing patients, he's doing integrated care work. So we're going to do this calculation to say, well, instead of him losing out on those RVUs, we're going to compensate him for that time because we know that his leadership role brings value to the organization. A stipend approach could just be a straight, hey, Dr. Smith's going to get $4,000 a year to be a champion, or $2 a year, whatever that going rate is. Protected time approach, that could be nice if you're in a salaried position or an academic setting where your leadership time is just blocked in your weekly schedule. Again, maybe it's Monday 1 to 3. That's the time that you are going to devote to those admin activities. And just know that that grows over time. When you start a pilot, sure, there's certain sites doing this and that's wonderful. But as you quickly scale up, there's going to be more and more time that those PCB champions need to invest in that. So I'd say leave room for growth. So that was a lot, and I will stop sharing. But that's my jam. I don't know. Any reflections on if that's making any sense or whatever? Just happy to hear your guys' thoughts.
It's Ashley. Well, Jen, I just have to say about the PCP champion aspect. Jen and I had a few meetings over the last couple of years to really help me be able to advocate in a way C-suite would be okay with us having PCP champions in our health system. And I have to say the persistence paid off.
Yeah.
Now we have a whole bunch of them. They don't get RVUs. They're actually just excited to teach their colleagues and to make suggestions for when placing a referral, like having a specific lab order set. They've even, participated in development of marketing materials for us. And that's been a really big win. So kudos, Jen. And it really does make a difference.
Okay. Oh, that's great. Wonderful.
I've got a question for you, Jen.
Yeah.
And it's nice to see you twice in one day.
I know, and I like that too.
So I actually have two questions. One is, do you have you had systems or do you give a higher RVU or just an RVU for the 99492 month? Because some systems will do that, first question. And second question is one of the things that systems found is helpful is to track the provider handoffs with tracking the conversion rate as a metric. So what percent of provider referrals convert into a 99492 or a billable first month of collaborative care? Because you do see a correlation between the handoff and also, some of it is care manager training, right, in terms of engagement or maybe some systems. But a lot of times, if you track that conversion rate by provider, you will be able to pick up differences in terms of some of the intro language. So just wondering if you do that in your system and what that looks like.
Great question. I wish we did. So full disclosure, my system, we don't have the best way of like tracking a lot of this. We have a rather old, I can say this in this company, Meditech Expanse EHR, which uh, it's not our best friend for like pulling data. So we're not very sophisticated. The examples I was giving around like, oh, you could do RVU credit or you could do protected time. That comes from like my amalgam of lived experience and travels of talking to different providers nationally that do this. My shop, I get a stipend. So they don't bother with like, oh, you get this. Like, we're not smart enough to do that. We just say, all right, Thomas, instead of you twiddling your thumbs for these hours, this is your stipend. You do this work for this number of hours. But I think that's a great concept. And I think you're right on the money that if you were able to zoom in to conversion factors for provider, you'd find the ones that are high performing where it goes well. And from, handoff to actual
Mhm.
care manager visit, the people that are bought in that really believe in the work, it's going to be easy and natural for them to have a better conversion rate. So I don't know if that's a crappy and non-answer, but I think that would be a smart approach.
Yeah, I think it's good because some of them feel compelled to like
Yeah.
explain what collaborative care is to patients
Yes.
and and that's a buzzkill, right? Like, no. And so, yeah, just giving them those one-liner handoffs is like optimal. But that's cool. Okay, thank you.
Yeah, no worries. Liz, you asked other examples of non-patient care activities. I mean, when we first got started, for me, it was having to, I don't want to say educate, but I did. I made a slide deck of like, this is what collaborative care is, and had to take it to our office managers and our receptionists and our mid-level managers on the hospital side, our hospital board. Nobody knew what integrated care was. I hate to say that, but they didn't. So like, we had to be the novice and the teacher at the same time, which is a really tough thing because you always sort of feel like the imposter that you're like, in this company, you guys, the national experts, are like, what do I know? But then in your own shop, you might be the one that knows about this. So you have to kind of walk that line and just get comfortable with the uncomfortable of like, all right, we're all learners and we're all teachers, if that makes sense. So non-patient care stuff. I was in on interviews for care managers because we found it was more helpful for me to like, hey, sit with you and talk with you. And this is what this would look like. Can I imagine myself doing a warm handoff with you? So I was kind of baked into some of those operations things that a physician normally wouldn't do, maybe. I do evaluations for the care managers. Now, again, my role, I've been doing this role officially since 2019. So I would say, don't take this as, oh my God, the PCP champion has to do all this from the jump. No, but years in, for me, it evolved more into a medical director role where there was more like leadership admin activities. But when you're getting started and it's just this PCP champion thing, sure, mainly it's not a huge time investment, but it's going to be involvement in some of those workflow conversations. Like when we first started, AIM Center had us walk through the readiness assessment tool, and we had to create a slide with the steps in the workflow. Somebody had to do that. So that was me and Kathy Rumbach. It was the research coordinator from Morris that was like, all right, we're doing this research study with AIMS. You guys figure out how to operationalize it. So it's some of that really unsexy work of like the nuts and bolts of operationalizing this, that having that provider champion I think helps. So yeah, I don't know. That's just some of the non-patient activity. Yeah. Sorry, am I freezing? I'm sorry if somebody says I'm freezing and dropping off. Sorry about that.
I think you've been on pretty steadily for me. So,
Okay.
hey, Jen, can I ask a question and maybe
Yeah.
get a little personal here? So one of the things, that care managers can do for doctors is really support them in understanding their workflows, their pressures, their stressors, and one of them is liability, right?
Mm.
Can you speak to how, care managers can, not technically reduce liability, but more eyes on, you
Yeah.
know, more touch points, things of that nature, because
Yeah.
that seems
Yeah.
to be a
Yeah, absolutely, absolutely. So I will share that in my own personal experience working in the model, and then also like championing other docs, clinicians of you should do this, liability does come up. I guess I reference like the stuff AIM Center taught us, or my good friend Laura Sideri that has those talking points around there's not case law to date that says like, hey, there's been this liability case around negligence with collaborative care. Again, speaking to that, it'd be pretty tough to prove that you were negligent because boy, collaborative care is pretty darn high level standard. If you're trying to achieve that and you have an interdisciplinary team and you're like, hey, I've got a site consultant I reached out to when we weren't sure what to do. I had a care manager that had eyes on helping me clarify diagnosis. It would be really hard to prove that the doc didn't do their due diligence and failed in their duty to their patient. Now, I'm not a lawyer, but to me, that tracks a little more and I can sleep at night on, hey, okay, I'm doing this together. There's that old, what I think Brandon Kate likes, don't worry alone. I'm like, yes, this helps me feel like I'm not worried alone, because what's the alternative? The same patient's still going to come into their PCP with the same, I might feel suicidal. They're still dealing with that. With this, now you've got a care manager you can pull in the room. Now you have a psychiatrist you can pull in. That feels better to providers than just the, here I am all by my lonesome figuring it out. So I don't know if that makes sense, Ben, but that's me.
Yeah, that's perfect. Thank you.
Okay.
So I'm going to jump in with another question there. If there's, since we have a national expert here. So one of the things that always seem to get doctors is that, we can save you time. I think there's research out there that, at least integrated behavioral health saves several minutes per patient, and can you talk a little bit about that, how that actually affects your daily, like, do you get lunch more than you used to, or do you get your notes done before other docs?
Yeah, that's a great question. I will give you my truthful answer. In my shop, we have a challenge around reach because in my system, we have a vast need and we've only been permitted to hire one. So I share a care manager with my nurse practitioner, and she also goes to 2 other primary care sites. So Verna and Ames is probably like, oh my God, don't say that. That's not fidelity to the model. It's not. I wish it was different. But here's the real world, right? The people who are the decision makers in my system decided, okay, I mean, that's cute. You want just one person, one care manager for you, but we're not doing that. We're going to spread them over 3 clinics. These are the fights.
Okay. I
It
think that's
is? Okay, good.
But I mean, ideally, you want someone to have a relationship, right?
Okay,
But over 3 clinics and 10
okay,
providers, like, as
okay,
long as they know that person, like, I don't think that's,
okay.
and then you could build, you do your pro forma, and then you could add them on from there. Like, is it ideal? But, I don't think you're straying from the fidelity there, my
Wonderful.
dear.
That's
Yeah.
good to hear, Verna. We always wonder about that. Like, oh crap, are we doing it right? Because
I was gonna say, don't you put the AIM Center in there like we would tell you that. Fidelity
no,
is
not at
about
all.
having those core pieces, but at the end of
Not
the
at
day,
all.
you need a
Yes,
sustainable program.
yes,
Yeah.
And so sometimes that one behavioral health care
yes,
manager to that
yes,
one clinic isn't producing enough patients to
yes,
have a
yes.
sustainable program on your registry. And so definitely does happen where you have behavioral health care managers covering
Sure.
multiple
Mhm.
clinics.
Yeah, especially to start. And then as you grow it, you identify populations, you train the providers get engaged, then you can walk it back and you can assign them to individual practices or
Okay.
providers. So
Okay. Okay. No, that's super helpful. Thank you, Monica and Verna. That's just our own, insecurity around like we're doing this by ourselves now. We got all this great hand holding and coaching. Now what? And I think that's just kind of you gotta learn by doing. So the question of do I get more time at lunch? Um, my honest answer is no, but I also feel less burned out. I feel more effective because I'm not dealing with all that by myself. I literally at lunch, and I get lunch, can sit with Melissa and be like, hey, what about this last one? Or, oh, this person coming in at 2, I need to tag you in on because I'm not sure what we're looking at for diagnosis. So, yeah, I don't know for me personally that I've ever been able, and maybe there is if somebody ever wanted to like watch my steps and like count count your minutes. We're not sophisticated like that. But what I do feel and can speak to is more efficient because I'm having other people help me navigate what's the next right step. Does that make sense? I don't know.
That's perfect. Thank you.
Okay.
there's a question in the chat. Jennifer, I'm wondering if you could speak to what you do. I know sometimes, are you ever using the interprofessional billing codes, or are you adding time and complexity to your E&M codes, based on some of the work that you're doing, or how has it changed your billing and coding?
For me on the clinical side,
For
what I
you as a PCP,
as a
right? So if you're
yes,
reviewing the psychiatric
yes,
consultation note or speaking
yeah.
to the care manager same day, like are you finding that you're adding to your E&M code and how often do you do that and what does that look like? Are you building the interprofessional codes like, where you're able to?
I'm not. Maybe I should be. Again, from the busy PCP standpoint, how it flows into my inbox every day is I get messages in my inbox from Melissa, care manager. Hey, I met with Dr. Norell today. We did psych or SCR. She thinks we should bump this med, and I'm going to screen for trauma. Great. I send the higher dose Lexapro. And then when I see that patient next week, I'm like, oh, okay, you had that PCL5. Ooh, there's some trauma here. Maybe we need to be talking Prazosin for your nightmares,
Mhm.
So I don't add any interdisciplinary codes, but I
Mhm.
do a lot of like asynchronous, I guess you could call it, back and forth with the with the care manager in my inbox because they meet and talk and connect with patients all throughout the week, not just when I happen to see the patient for a visit or when
Mhm.
care manager and psych consultants sit down for the SCR. So I think that's something that at first, I will say, like when we very, very first started, I was like, "Oh, holy cow, we got more messages in the inbox because we're doing this." And that's okay because you're doing it more efficiently and you're addressing things that otherwise would have just gotten ignored or needs would have gone unmet and who knows what would have happened to those things. So instead of just not knowing that, oh, this person has a mood disorder diagnosis, okay, the psych consultant's really coaching us up on, yes, we think that's the case. Let's try this med. And if these things aren't working well, maybe we do need to bridge their care to specialty mental health. So, I don't know. I guess I feel like the trade-off is sure, you might have I hate to say a few more messages, but that was the truth. But the providers in our system that have driven the like, we need this, we're not going back. Um, they've felt the value of it that I don't hear them crabbing about like, oh, I get 10 more messages and I don't, 3 or 4 more messages a day. In our system, we started off with primary care and OB-GYN of all places.
Mhm.
Like that was
Mhm.
a tough sell, right? The gynae is like, oh, you're going to be the psych prescriber. But honestly, it was the obstacle turned opportunity in our system. That private practice just got acquired by the hospital. They didn't take Medicaid historically. Now they did. Now they have these clients that have, mood stabilizers and other social determinants of health. And they're like, I can't just refer to psych to know what meds are okay in pregnancy and breastfeeding. So having a psych consultant, having the triangle really relieved the pressure of what do I do for this patient regarding the
Mhm.
meds. So
So I just want to go back to something you said that I caught that the care manager puts the recommendations in. It come from the prescriber directly to you?
yes, the
Oh,
psychiatrist, it does.
yeah.
Yes. So like how it'll look in our EHR, it's kind of clunky, is psychiatrists will be like, hey, Dr. Thomas, I met with Melissa, care manager
Mhm.
today. Here's the scores. Here's what we talked about. Here's my recommendation. And
Mhm.
then in our EHR, we get 2 recipients. So it's almost like a CC. So it goes to Melissa, the care manager, and me as the PCP. So
Uh,
sometimes, yeah, that's just kind of how it comes to me is like it's to both of us. And then I then take the ball and say, okay, Melissa, the plan is Lexapro 20. Give Joe a call and let him know I sent that so that when he comes in next week, he's already taking that med and we're acting on it today rather than waiting for our next office visit.
Right. We did put the interprofessional CPT codes in the chat just for folks.
Cool.
And then there's a comment, the PCP and CM count towards the monthly CoCM code. So if you're talking to the care manager counts that time. You don't bill and code for that time unless you do it through the interprofessional code or an upgraded CPT code. It doesn't count towards the collaborative care minutes. I mean, people know that probably in this group, but just
So Verna, using those codes would be if Jen talked to the psychiatric consultant. Would that
could
be?
be,
Yeah.
yeah, yeah, or even initiating. So if she was said, you know what, I'm going to bump this to the psych consultant right away, right? Because I saw the patient today, they're having a side effects. I want to communicate with them directly. That happens as well. So yeah, I think it's helpful to look at the interprofessional codes, some of the case conferencing codes, and just have them because there are opportunities maybe to use them.
Do you know an average of those get paid? How they? how much they get paid?
It's gonna vary. I can pull it up on the Medicare
Oh,
list.
yeah, I get
And actually I'll throw it in the chat for people. And then it usually the private, the commercial plans will follow Medicaid, but or
Oh, you just want to mute Berna.
I'll put it in the chat, the
Thank you.
payment.
Jan, I have another question for you. The name of the presentation is the PCP champion, but what about nurses and MAs? Those folks tend to
Mhm.
drive
Mhm.
as
Yep.
a son of a head
Yeah.
nurse at a hospital, they
Yeah.
run things. So
Yep. Yep.
can you speak to that a
Yes.
little bit?
Absolutely. I would hope everybody gets a amazing nurse like I have. Jen Blazevich, she is the most warm, caring nurse ever, but her heart is in, yes, primary care. She has some lived experience, I think with family members. And like, so when the work comes down to I'm championing this to my fellow nurses who can get kind of salty about like, why are we dealing with this? Thomas's messages are long and complex. I don't want to deal with them. Um, Jen, in her values and in her rewarding work that she does as a nurse I get to work with, gets to model the whole like, well, hey, this is whole person care. It's primary care. These are the things coming in our door. So we've got to figure out how to at least address them. Not that we have to care for all things and go outside scope, but we have to start with unpacking that. And can we deal with it here in collaborative care? Great. They're getting better. Nope. We need to bridge to specialty care. That's okay. So I think what I would say to that is, really encouraging champions at all levels. Even our there's a receptionist, we call them PSRs, at one of my offices in Gardner, that just really this work clicks with her. So she champions that and parrots that when she talks to her other receptionists of like, hey, isn't it cool that at Gardner we can do behavioral health and physical health care? And people like that. So whatever talking points they need, it is a bit of culture transformation that you just get people thinking in that mindset of this is how we do business as usual. This is, behavioral health is part of the primary care chronic disease lens. So come on down.
I have a quick question, Julian here. I'm curious to hear some of your strategies for how either the PCP champion or other members of the collaborative care team can be successful at engaging PCPs or their colleagues who are just not referring as much. So what are some strategies or te
Yeah.
techniques that you've seen to be particularly successful?
Yeah, that's a great question. I think it has to be about internal champions that can be their own advocate for the work. So my system's kind of spread out over like 5 geographic counties. So even though I'm PCP champion or now medical director, one of the things I've found successful was going on a little field trip to all of those primary care sites. And you kind of feel like the drug rep. It's like, hey, it's lunchtime. I'm taking a minute of your time, but I want to sit and talk with you, Dr. Jones, about how this is working. And then if they have that opportunity to reflect back to you as a colleague around like, well, what I don't like about it is, they're not interruptible or whatever, right? Like I can't pull them out of a room. What if they're already with their client, and I'm like, okay, let's problem solve that. We can do a referral and they can give that patient a call right as soon as they leave that encounter and do the next one. Or you might find that every office has a bit of drift where people get the triangle and the approach and then they go apply it in the real world and you find really quickly things get off the rails. So I think having that designated time to like build relationship between peers of like, hey, I'm in the trenches with you. I do this in my shop, and yeah, it's messy and it gets tough. But here's why it works for me. Tell me what pain points you're having, and maybe we can kind of tighten that up and problem solve that around there. So I think it speaks to like office culture. Because yeah, I guess you're gonna have your early adopters that are like the rah-rah cheerleaders of like, yeah, this is great. And then you have some that are sort of like, nah, whatever. And then you got that other group that's sort of a heck no. So I think you have to kind of tailor your approach for those audiences of how you approach it. Like, again, that example I gave of the Doc Smith who was like, hell no, we shouldn't be doing psychiatry stuff. we had to unintentionally model that for him. He had to see his colleagues on his office hallway with a care manager going in and out of the rooms with other docs and seeing their patients for him to go like, well, maybe there's something to that. So that took time. Like it was a time investment. So it was sort of the, you can lead him to water, but can't make him drink. He had to come around to that realization of like, well, if it's working for my colleagues, maybe it could work for me. But it's tough. I think shoving it down people's throats ain't going to work, especially if you're not reflective of the context and culture of those providers. So I guess my bottom line rambling answer is just try to build relationship. If it's your job, if you're the champion, the director, whatever, of like, I'm trying to get the momentum going in my system,
Yeah, for sure.
try to make time for those folks and really like, what's it like for you? What's going well? What's not? And try to be actionable around that.
Great. Thank you. Yeah.
Sure.
One of the metrics that we follow is the percentage of referrals across all providers. So it shows this or the movement from the champion to the other providers. And as that percentage goes up, that's when we kind of see it as a more mature, engagement. So
I'd also say don't underestimate like a care manager humble brag, right? Like in a meeting and other things to like
There
call
you go.
out like Dr. Smith, I saw your patient and this is what we did and they got so much better. Like I think we're not good at self-promotion and I think if we can teach the care managers self-promotion like in across settings, like don't just
Yes.
call it out when they're not doing well, call it out when they're doing great because it means you did good work and you should think about that type of patient next time and refer.
Agree. That's so true. In your shop, Kristen, are they all in-person care managers or is it all virtual work? Because I know that's a little different nuance too, right? What does it look like in your shop for your teams?
Yeah, agreed. We have a little bit of both, and that is, of course, easier when you're in person. Like it feels like a thing when you're reaching out virtually.
Mhm.
And I also tell the care managers, like, we've never had a PCP be like, stop messaging me good news, right? So, um, I feel
Yeah,
like if you feel like you're over communicating, you're probably doing it about the right amount.
absolutely. And I think that, I mean, I'd be curious so my lived experience is my care managers are live in clinic. I think it could be challenging to get that PCP care manager relationship built in the virtual environment, but maybe not. It's doable, right? Like, so my psychiatrist has always been virtual. I've never had an in-person psychiatrist. She's in Virginia. I'm in Illinois. She's amazing. But how did that happen? It's fit, right? It's a fit. She's a constant liaison background. She likes talking, teaching the way I just putting it out there. I've had other psychiatrists on our teams that just don't have a way of talking, writing, even in those brief little consult notes in the EHR that don't feel empowering, right? The quickest way to turn off a PCP, and we had this on the PED side, is we had a provider, a psychiatrist that wasn't super friendly or approachable. I experienced that on the receiving end, even as our director of like, oh, I kind of felt like that was a dumb question. Like, I'm less likely to reach out to him next time. Different vibe, different culture than Dr. Norell, where I'm like, I can ask her anything. There's psychological safety there. I don't feel like, duh, you should have known that. It was thanks for bringing that. Let's talk about it together. So that's tough thing that's not, I don't know if it's teachable, coachable, but I think that is a big piece of the secret sauce with this is that the triangle people, including the patient, know who those people are and trust each other and can really say, hey, Mike or Melissa, whoever your care manager is, we work together all day, every day. And, we can approach this as a team. So
Well said. Hey, Monica, I see your hand.
Yeah, I was just gonna comment on that what you were saying, Jen, about like you're used to yours being on site. I was actually having this conversation with a individual at an organization last week, with their preference being, their behavioral health care managers on site and can engage with their medical providers. And I do think that engagement is important, but I just also wanted to I'm always like, I'm gonna play the other side of this too for you, not the devil's advocate because I don't believe that. But I'm gonna play the other side of this for you too, and that there is research out there that actually shows that those patient outcomes for those that are doing virtual collaborative care is good. Like there's nothing that says like, oh no, in person, or at least let me not say there's nothing that is nothing that I have seen yet that says that like, oh, in person behavioral health care manager providing collaborative care is 1,000 times more effective than someone doing virtual. So, but it's just a hard thing to wrap your mind around. But like I hear you when you talk about your site consultant, right, who finds these ways to still engage with you all as a team. I think it's the same thing for the behavioral health care manager that's virtual. Like it still should be that they're finding these ways to still engage with that healthcare team that they may not be seeing every day.
Yes, absolutely. Yeah, and maybe it's you invite them to the provider meeting. We've done that, like,
Right.
because it's a virtual provider meeting. We all work in the same system, but we don't all drive to Morris Hospital. We jump on a Zoom. So having here's her face, Melissa. Okay, it's face to a name. That counts for something, you know. So in the virtual environment, you can still have those touch points and get to know people, even if it isn't in person.
And it looks like Michael in the chat, Jennifer, others, could you share reference for the 30 to 50% full response after a first CoCM visit?
That's a good question. I can't off the top of my head, but the gist with that stat was not a lot of people get better on the first try. I don't know, AIM Center's probably got a lot more sophisticated quote for that it takes time. It's not common that we get it right on the first try, right? We're like, everybody that comes into primary care with depression, we make a treatment plan and they're better. I don't know if anybody from AIMS can bail me out on the better way of phrasing that, but essentially it takes sometimes a couple of iterations to get patients better. Is that, I don't know, anybody else have anything to add on that?
Are you referring to treatment interventions, or that it takes longer for some patients to improve, or different iterations of episodes of care?
Good question. I think we're kind of just speaking to the whole point that in usual care, patients oftentimes don't respond to the first. I think it's an antidepressant. Isn't that the stat around that was built?
Yeah.
Yeah.
Yep.
Okay. Annie, you're smarter than that. Tell me. I think
No,
that's the gist,
I
right?
don't know if I have it memorized, but there is a large percentage, it's up to 70% that need an additional medication
Okay.
and treatment change. So it can be a large handful of folks that are not gonna, where we hit the nail on the head with the first recommendation, and that turns out to be a great fit for them. That's the goal, but that doesn't always happen. So I think
There we go.
yeah,
What she said.
I think Sarah put in the chat on our name center resource that at the very bottom it takes a team, and that references only 30 to 50% of patients have full response in the first treatment. So
I couldn't find a more academic or peer-reviewed citation other than the AIMS Center resource. My understanding is sort of what the discussion has been, that it's not really about the first visit, it's about the first treatment, the first medication, the first brief behavioral intervention. That you don't want to wait too long if the first treatment that was tried isn't working until you staff the case with a psychiatric consultant, make adjustments to try to help the patient get better.
Can I ask a question? Ashley, I think, and then Dr. Clark put in the chat about sort of giving low referrers extra attention or maybe bringing that up at provider meetings. How do you do that without PCP sort of feeling like you're putting them on blast?
So, great question. So thankfully, our healthcare system already puts them on blast for a lot of other things, including how they're doing with second blood pressure readings, and are they referring to like the diabetes educator, how many referrals per month are you making? Are your patients' A1Cs, lowering? Are you getting them in for visits? So they're already put on blast. So that gives us permission for transparency. And so actually the conversations have been really helpful that we've had. I have an Excel sheet. I'll do like a snapshot. I'll share my screen at a provider meeting if I'm joining as the manager of the program, and say, great job, like, XYZ provider, how was your experience, last month? And they'll say some sort of anecdotal comment. And then I'll say, oh, like Dr. So-and-so, were you on vacation last month? And they'll say, well, no. And I'll be like, okay, so what do you think, got in the way? And so we'll have conversations in the moment, but I think that's our culture, right? That I'm tapping into that is already in existence is, there's a lot of talk. So I'm at Hartford Healthcare in Connecticut. There's a lot of talk recently about like using the care team approach. And the way to do that is actually having these conversations and pointing out the opportunities where they're maybe not thinking of patients, and then I'll offer, if they're a low referrer, either our PCP champion, Dr. Sampson will have some one-to-one time with them because maybe there's barriers they're not expressing in the moment, and that's okay. But I'll offer to scrub their schedule. And I typically, I think only one provider over the last, however many years that says no to that. And that's okay. So the transparency, I'm just stepping into that culture that's already in existence and capitalizing on it fully.
I can add, I think you also capitalizing on like competitive nature of a lot of providers is also really helpful. So one thing I used to do is provide kind of opportunity scores to people. Like if they had, the amount of patients they had that scored in a range that should have warranted a referral to CoCM. So, the amounts of referrals and missed opportunities, and everyone had a score, and that was shared with them individually, kind of like a report card. But then sharing the high performers data with everyone, and then people look at where they're standing and look at that, and they're like, that doesn't feel as good. But then also having those higher performers really share with their colleagues what they're doing, how they're utilizing the program, how they're identifying patients, how they're pitching it to patients. So hearing from those high performers and having them speak directly to their colleagues, I think can be pretty impactful.
And I'll just say like a little bit of and consider the flip side. We get messaging all the time with how we're not meeting the mark. So I was going to see if I could share this. You see this? This is my metric. You see a lot of red on there? We don't like that. It's not because we're like, don't tell me I'm a bad doctor. A lot of this feels out of our control. So my tip is reframe it, flip the script on the language. You're not a low performer. How can I help you problem solve your pain points? Just be careful of unintentionally making people feel like they're not doing enough, because we get that all the time with the blood pressure and the A1C and everything, and it's tough. So anytime you can do strength-based feedback, hey, I really liked when you did refer that one patient, and didn't that feel good? Zoom in on that versus the 99 you didn't refer. I don't know, just my 2 cents.
Annie, do you want to finish up with the comment on
Yeah,
the
sure. I just plopped into the chat the survey that was created. Thank you, Hannah. Of the information that we want to include in the CoCM SIG directory. So we'll be sharing this frequently until we get information from most people, and then sharing it with new people. And so I don't know exactly what the platform or layout of the actual directory will look like yet, but there are a few options we're considering. But if everyone could complete that survey, if you would like to be included in the directory, that would be great.
Yay. All right. Thanks for letting me talk. This has been
Thank you, Jen.
yes.
That was so great.
I hope I know y'all are a safe psychological space where it's like, I feel a little vulnerable with y'all. Like, this is what this is N of one. This is just what my lived experience is. I hope it's somewhat relatable and helps you a little bit with the providers you're dealing with. But end of the day, keep showing up, keep talking, keep building relationship. You're doing better than you think you are.
Thank you, Jen. That was great.
Jen?
Thanks, Jen.
All right. Have a good day, everybody.